Team, whenever you are ready, you just give me a countdown so that we'll take it further.
Dr. Kasi, I have some problems with the internet, so I am on the mobile data.
We are
absolutely
live.
No problem, sir. If it is worse, you switch off the video, then we'll be able to hear you. That will be the last result of management of the data bandwidth.
Okay.
Sir, we will be live in 3, 2, 1.
Good evening, friends. It is indeed a pride and privilege for all of us here to meet you this evening for this very important academic deliberation on the burning subject of post-cholecystectomy leaks. Ladies and gentlemen, we have two very eminent speakers and a giant of academics. We have I'm sorry about that connection issue. We have one of the very senior most moderator, academician, an astute laparoscopic surgeon, Dr. John Thanakumar, have made himself available for this evening to moderate the session. IAGES, I also warmly welcome the president and the secretary of the IAGES, and I thank the president and the entire EC for allowing us to do this IAGES prime time on a monthly basis, showcasing the best of talents across the globe. We move on to various subspecialties, for which today it is going to be on the management of the post-cholecystectomy leaks. Ladies and gentlemen, can I have the honor of inviting and listening to our president, Dr. S. Ishwarmurthy. Yes, sir.
My dear IAGES members, invited faculty, friends, viewers across the globe, and ladies and gentlemen. It's indeed a great pleasure to meet you in this IAGES prime time today. Thanks to Dr. Kanagavel and the blessing of all our predecessor presidents and all our EC members, we are now going across the country to conduct various fellowship educational programs, and out of which IAGES Prime Time Online is the one prime important thing, reaching the global audience, as you can see. And friends, last month, we just returned after doing 4 academic programs in one city of Pondicherry, wherein we did the advanced upper GI course at JIPMER and also the fellowship in laparoscopy, endoscopy, and postgraduate training program in MGM Pondicherry, with enthusiastic faculty and also very engaging all these students. So it's very, very heartening to see them all. And with the same momentum, we are now going this coming weeks in 14th to 16th July to Hosur to conduct a twin treats academics, that is FAGS, that is the essential laparoscopy course, and EFAGS, which is a basic endoscopy training course for surgeons. Subsequently, we'll be reaching to GSL Medical College, Rajamundry, to do the first ever hands-on ERCP training course for surgeons. We call it 4G ERCP on 11th to 13th August. And we know that there is a lot of interest in learning the art and science of herniology. So we have the advanced training course in hernia. Already we did one in Mumbai. Now we are going next on 18th to 20th August to Max Hospital in Delhi, followed by one in Vijayawada in late September, and finally in November we'll be going to Bareilly in UP. So a lot to look for. And also, as you know, friends, this is the first time we are going along with 100 of our colleagues to Edinburgh to have the IAGES Royal College of Surgeons Collaborative Conference Indo-UK Surgicon 2023 on 9th and 10th October. Please, if you are interested, go to the www.indo-uksurgicon2023.com to register, so that you will be also be considered for a faculty position. And at the fag end of our academic year, we'll be meeting in the City of Lakes in Bhopal for our midterm conference on the 28th and 29th, along with our fellowship programs the couple of days before the conference. And finally, thanks to Zamir Basa, Sivakumar, and Kanakavel, Govindraj, and Rajavel, we'll be convening in Chennai for our annual conference and convocation in Taj Coromandel. So, ladies and gentlemen, it will be going to be a very busy academic year for all of us. In the meantime, I welcome you all for today's IAGES Prime Time, where Dr. John Thanakumar, our senior advisor, Anurag Hospital, Coimbatore, will moderate a session which is very, very important as far as the management of post-cholecystectomy bile. To know the role of imaging, let us listen to Dr. Venkatesh Kasi, followed by how an endoscopist with the endotherapy modalities can treat the patient with the post-cholecystectomy bile. We have none other than Dr. Kumar Krishnan, is assistant professor of medicine from Harvard Medical School. So there is a lot more to look for, and I thank you once again for having joined today in the IAGES Prime Time. And please go to IAGES.in to know all our academic and social activities, and also be active in our Facebook also. Until we see again, thank you again, and let us go to Kanagwel to start the proceedings of today. Thank you.
Thank you, President. Thank you for giving us the glimpses of various academic activities completed and more to follow for the coming year. And we look forward to have the international event with the IAGES Edinburgh soon. So friends, without much ado, I now hand over the evening's proceedings to Professor John Thanakumar sir to briefly introduce Professor John as a matter of protocol. John is a very eminent laparoscopic surgeon. He has authored himself books, Basic Laparoscopy, and he has been always contributing to the IAGES publications, the textbook of surgery, laparoscopic minimal access surgery. And he has been contributing regularly to the Journal of Minimal Access Surgery, the flagship journal of the society. Ladies and gentlemen, Dr. John has a very glorious studentship at Christian Medical College, Belur. Then he finished his master's at very eminent professors at the Christian Medical College. Then on, there is no looking back. He has traveled across the globe to acquire the knowledge. And to inform all of you, from the inception of the IAGES have been actively teaching at various levels for young surgeons and practicing surgeons about basics, advanced and innovative surgical techniques. Dr. John takes very special interest to teach the youngsters. And right now, IAGES has taken a very unique initiative to train the surgeons in training, the surgery residents. And very recently, Dr. John Thanakumar successfully completed a full-day postgraduate resident minimal access surgery program at Pondicherry. And it was a huge success with students more than 150 joining to their hands to be part of us. With that few words, I have the honor of inviting Dr. John sir to conduct the evening proceedings, and I hand over the evening to him. Dr. John, the stage is yours.
Thank you, Dr. Vale, and thank you, Mr. President, Dr. Iswaramurthy, for your kind words. Today's IAGES Prime Time is on imaging for post-cholecystectomy bile by Dr. Venkatesh Kasi, followed by endotherapy for post-cholecystectomy bile by Dr. Kumar Krishnan. I have the unique pleasure on this evening with my special greetings on Eid Mubarak to you on introducing Dr. Venkatesh Kasi, who is son of the soil for me. He is from Coimbatore, at least he works Coimbatore in Kobe Medical Center. He is a lead consultant, Division of Abdominal Transplant Imaging and Ablative Therapies. His main interest lies in divisions of abdomen, oncology, and transplants. He studied in Stanley Medical College, followed by Chipma, followed by Amrita, followed by Italy, and he has certification in Europe. So without much ado, I request Dr. Venkatesh Kasi to go ahead with the speech. Dr. Kasi.
Thank you, sir. Thanks for that nice introduction. I'd like to share the screen.
Yes, we have it. Yes,
So can
we
you see
have
my
it.
full screen?
Yes, we can see that.
Thank you, sir. I would like to thank IAGES for giving me this opportunity, and I would like to thank Dr. John Tanagama sir for this introduction. And today's topic, we are just going to see a few points about the imaging for the post-cholecystectomy bile leak. And if you take the imaging for the post-cholecystectomy bile leak, so as we all know, there are two types of cholecystectomy. There is no need for telling that. But if you take that, one is the open type and another one is the laparoscopic. And in the recent years, there's increased number of laparoscopic cholecystectomy are happening, not only secondary to the advances in the hardware, but also there is an increase in the indications also. So though, if you take the patient improvement, the number of days in the hospital, the laparoscopic definitely scores over the open cholecystectomy. But in few areas, if you take the complications like the hemorrhage, and if you take the biliary injuries, still in the experienced hands, the laparoscopic and open cholecystectomy weighs the same. But in the inexperienced hands, the laparoscopic in the injury of the bile ducts are more with the laparoscopic cholecystectomy compared to that of the open cholecystectomy, which is the topic we are going to discuss today. So though they have mentioned a lot of complications in the cholecystectomy here, only the two things what we are going to see is that the biliary injury and the leak. So if we take the grading of bile leak by the IAGES, the group of the liver surgeons, they are divided into three: the grade A, the grade B, and the grade C. The grade A is the most common and it has a little or no impact in the patient management. And the grade B is managed by the endoscopic or percutaneous procedure. And grade C, it represents a severely compromised clinical condition. In these conditions, the IAGES recommends a surgical approach. So why these ducts are getting injured when you do the cholecystectomy? Definitely the radiologist also should know about the variants which make the prone for the injury. The first one is the lower medial insertion of the cystic duct into the common bile duct. And second one is that the common sheath where the shared by the common bile duct and the cystic duct, they run a parallel course. So these two make the cystic duct little more prone for that of the injury during the cholecystectomy. The other variations, what you should be aware is the one is the right anterior duct, which has a separate lower insertion into the common hepatic duct. And then the next variation is a triple confluence, where the right anterior, the right posterior, and left hepatic ducts are opening into the CHT. Then the next comes to the most important one is the aberrant right posterior hepatic duct. This aberrant right posterior hepatic duct, they join separately into the common hepatic duct or the cystic duct, and they are seen in the callus triangle where they are prone for the bile duct ligation due to its proximity. So other two things I want to emphasize is the one is that the subvesical bile ducts or the ducts of the Laska, which are the accessory bile ducts, and they run in proximity with the gallbladder fossa, which is typically originate from the right hepatic lobe. And this is the second most common cause for the post-cholecystectomy bile leaks after the cystic duct leaks. So what are the other factors which are the prone for injury? One is the gallbladder pathology, which includes the acute cholecystatics or the fibrotic type of the gallbladders, or it may be related to the patient-related factors, which include the excessive fat within the hepatoduodenal ligaments, the male sex, the older age, the cirrhosis, and obesity, then the operator-dependent factors. So what are the clinical presentation normally this bile leak will present with? They will usually present with within a week or 10 days, and with a vague non-specific symptom, which including the abdominal symptoms such as bloating, abdominal pain, anorexia, or malaise, as well as they can have some signs like jaundice, peritonitis, the cholangitis, and the most important one is the continuous bilious output in the surgically placed drains. Whenever you are appreciating the continuous bilious output in the surgically placed drains, then you should rule out the bile leak. So when you want to evaluate the bile leak, the modalities what we have is we have ultrasound, we have CT, we have MRI, we have the scintigraphy, and the last two is the percutaneous transhepatic cholangiopancreatography, ATC, and the ERCP. And the important aim of the imaging is to first, whether there's a leak is there or not. Second, the site of the leak. Third, the length of the injured areas. And These are the important things which has to be addressed by these modalities. If you come to the ultrasound, ultrasound is easily available, it's cheap, but and it is the initial imaging of the choice for the evaluation of the patients with abdominal pain. And in this CPC, in the case of the bile, the two things what you will see, you may appreciate a fluid collection, or you may appreciate the dilatation of the biliary radicals. The fluid collection can be anechoic, or it can present with that of the septations. But the disadvantage with the ultrasound is they won't be able to tell whether the fluid collection is secondary to the bile, or secondary to the seroma, or secondary to the hematoma. So these are the things which will be very difficult with the ultrasound to tell. And the disadvantages, another disadvantage is the operator-dependent modality. When it comes to the CTs are usually taken when the patient is presented with the diffuse abdominal pain and the sepsis. They are also able to identify the collection. The sensitivity for picking up the collection is large, but still, like ultrasound, it lacks the specificity to tell whether it's a bile or the not. And if it is a infected fluid collection, you may appreciate an enhancing wall following the contrast injection, but still it's not going to tell whether it's a biloma or any other collection. There is a period where the people started using the drip infusion CT cholangiography, but in the drip infusion CT cholangiography, if you take, they are associated with the infusion reactions, and some of this contrast is not available in most of the countries. So because of that, the drip infusion CT cholangiography, it was not a successful imaging modality for evaluation of the biliary radicals. The next comes the hepatobiliary scintigraphy. When it comes to hepatobiliary scintigraphy, it is again a non-invasive modality that is more specific for the bileaks and bileaks than the ultrasound and CT. But the problem with the hepatobiliary scintigraphy is a poor spatial resolution and its inability to confidently identify the involved bile duct. The next important thing, what it could not do is, it won't be able to evaluate the extrabiliary structures, which is not evaluated. So there won't be any information about them. And now the hepatobiliary scintigraphy, it is added with the spexity that improves the localization. But again, the spatial resolution is not as that of the CT or that of the MR. Not only that, in the spexity, there is definitely, there's a radiation is also a part of the spexity. So next comes is the invasive procedure. Before seeing about the MR cholangiography, we'll just see these two modalities. Both are ERCP and PTC, both are diagnostic and both are therapeutic also. And they are invasive and they're having their own complications like the acute pancreatitis, hemorrhage, perforation, and infections. And in these both investigations, both if you take the ERCP or the PTC, they won't be able to evaluate the biliary, which is proximal to the major transaction in the case of the ERCP and distal to the major transaction in the case of the PTC. And also, there is a lack of, again, the same thing, whatever happened in the hepatobiliary scintigraphy, we won't be able to evaluate the extrabiliary structures. The problems which are going in the extrabiliary structures won't be evaluated with these two investigations. So when it comes to the investigation for the evaluation of the bile leak, the first thing is the imaging, the investigation of choice is the MR cholangiography. So magnetic resonance cholangiography, which is a non-invasive modality. There is no radiation involved. And it has a high spatial and contrast resolution, which can provide better delineation of the biliary and better recognition of the level and the length of the injury. And the routine T2 weighted imaging, which is done for the conventional MR cholangiography, can very well delineate the biliary anatomy. But the problem with this routine conventional cholangiography is it provides the very good anatomical detail, but it's not able to provide the functional detail. So sometimes it won't be able to distinguish the biloma, and sometimes it won't be able to
Please close your audio. Yes, go ahead.
Okay. Sometimes it won't be, you won't be able to distinguish the biloma from that other fluid collection. So sometimes it will be very difficult to identify the site of the leak also with the conventional MR cholangiography. So the conventional MR cholangiography, if you take in our terms, we'll use both T2 and T1 weighted images, and we will also take the sequences, the heavily T2 weighted sequences, which is meant for the evaluation of the biliary radicals alone. Wherever there is a fluid, that will be popped up, that will be seen as an hyperintense structures, and the rest of the areas will be suppressed. So that sequences also we will do. But if you're going to use the hepatobiliary specific contrast agent, then we should utter all these T2 sequences before giving the contrast itself, because This hepatobiliary specific contrast agent will cause T2 shortening, so that result in the poor quality of the T2 weighted images. So this is about the conventional magnetic resonance cholangiography. The advantages are it depicts the biliary tract above and below the tight strictures or obstruction, which is not possible by the ERCP and PTC, as well as it can evaluate the level, degree, and length of the biliary stricture, which is very crucial information for the appropriate therapeutic choice. The pitfalls are the tendency to overestimate the caliber changes. That is a pitfall, and pneumoblia sometimes won't help to evaluate whenever there's a pneumoblia, it won't be possible to evaluate the dilated biliary radicals in a proper way. Then magnetic susceptibility artifact from metallic clips, that also will definitely interfere with the imaging. Then there is a flow artifact at the common hepatic tract, as well as the superimposition of the fluid collection. These are the pitfalls which is associated with the conventional MR cholangiography. So the next comes the contrast enhanced MR cholangiography. In this contrast enhanced MR cholangiography, what we are going to give is we are going to give the extra contrast, the IV contrast, intravenous contrast we are going to give. That's a hepatobiliary contrast agents. So these hepatobiliary contrast agents will be taken up by the hepatocytes and that is secreted into the bile, and that opacifies the bile, that causes the T1, that causes a shortening of the T1 time of the bile, which ends in appearance of the bile. The bile appears as a hyperintense structure. That means it appears as a white structure, so that it will be very well visualized. So this is very useful to differentiate between the fluid collection of the biliary and non-biliary origin, as well as the specificity in picking up the active bile leak is 100% when you're using the contrast enhanced MR cholangiography. It can also depict the other surgical complications, including the biliary strictures. So the contrast enhanced MR cholangiography, the three most commonly used contrasts are the mangophobidate trisodium, which is the Tesla scan by the GE Healthcare, and then the multi-hands, that is the gadopenate dimethylamine, and the gadoxetate disodium, that is the GDUOP DTPA, the Primovist. So in this, if you take the Tesla scan, this is one of the first approved hepatobiliary contrast agent. But the problem with this contrast is it's solely a hepatobiliary specific agent. So we won't be able to assess the dynamic imaging, is not at all possible with this contrast. And there's also a concern of toxicity, so we are not using this contrast at present. And when it comes to the multi-hands and the Primovist, the Primovist is not available in India. The multi-hands is the only contrast which is hepatobiliary contrast agent, which is a hepatobiliary specific contrast agent which is available in India is the multi-hands, the MR contrast agent. So both multi-hands as well as the Primovist, that is the gadopenate dimethylamine and gadoxetate disodium, both give us with this contrast agent, we can do both the dynamic imaging as well as we can do the delayed hepatobiliary imaging. The difference between these two contrasts is only 3 to 5% of the multi-hands is excreted in the bile, allowing for the biliary imaging at about 45 minutes after the injection. But if you take the gadolinium UOP DTPA, 50% of it is excreted in the bile, allowed for the improved and early biliary imaging at 20 minutes itself. So whenever there is a suspicion of the bile leak, so whether we are giving a multi-hands or the Primovist, it is always better to do the imaging at multiple intervals. So they are mentioned that it's a combined imaging at 20 minutes, the 60 to 90 minutes, and 150 to 180 minutes delayed imaging. It improves the sensitivity of the biliary leakage. But the important point here is it is associated with the liver function. The liver has to function very well for taking the contrast and excreting the contrast into that of the bile. If the liver function is good, the contrast enhanced MR cholangiography, they will give a good result about the bile leaks. So if you take in this example, this is a pre-contrast. The first one is the pre-contrast. The second one is 20 minutes delayed image, and third image is the 35 minutes delayed image. If you see in the pre-contrast, there is a collection which is seen along the right lateral aspect of the liver. And in the case of the 20 minutes delayed image, there's a mild increase in the intensity of the collection in the non-dependent portion. And when you take at the 35 minutes, there is definitely significant increase in the intensity of the collections. So that shows definite bile leak. So this is how the bile leak will be very well demonstrated in the contrast enhanced MR cholangiography. So the contrast enhanced MR cholangiography, it demonstrates the anatomic site of leakage, it demonstrates the type of bile duct injury, and as well as it is helpful for assessing the degree of obstruction according to the presence or absence of contrast material in the bile duct. So when it comes to the bile duct injury, so there are various classifications are used in the bile duct injury, and out of these classifications, classification like Stewart, Way, Hanover, or Strasbourg-Bismuth. The most commonly used classification is the Strasbourg-Bismuth classification, where they classified the bile duct injury into 5 types. The type A is the leakage at the cystic duct. The type B is occlusion at the aberrant right posterior hepatic duct, and type C is the leakage or the transection at the aberrant right hepatic duct, and type D is a partial injury to the common hepatic duct or CBD in the lateral wall, and from E to E5 is the Bismuth modification, where the injury to the main hepatic duct and its relation to the confluence. If it is more than 2 centimeters away from the confluence, it is E1. Less than 2 centimeters away from the confluence, it is E2. And it is at the confluence with the preservation of the communication between the right and left, that is E3. When the communication between the right and left is also involved, it is E4. And when the injury to the common hepatic duct is associated with the aberrant right posterior hepatic duct injury, then it is E5. So if we take the bile duct injury, the type A bile duct injury, as we discussed, it's a leak from the cystic duct or the ducts of the Leska, and they normally usually occur when the clips on the cystic duct is dislodged, but can also occur secondary to the ductal necrosis or secondary to the distal obstruction by a stone or laceration to the cystic duct. The leaks from the Leska ducts, the smaller ducts of Leska, usually occurs whenever there is a presence of an anatomic abnormality such as intrahepatic portion of the gallbladder or an adherent gallbladder from the chronic cholecystitis. So here the MR cholangiopancreatography is going to demonstrate a fluid collection within the gallbladder fossa, and sometimes it can demonstrate a small connection between the fluid collection and the cystic duct. In contrast enhanced MRC, we may see an extravasation of the contrast agent from the cystic duct or the duct of Leska into the collections. As you are seeing in this image, this is an axial T2 image where there's a loculated fluid collection in the GB fossa, and this is a contrast 60-minute injection image where you can see the jet of contrast from the ducts of Leska into that of the bile leak. So this is a type A injury. And when it comes to the type B injury, that is secondary to that of the occlusion of the aberrant right hepatic duct. So when the duct is occluded, that ends in the dilatation of the biliary radicals. Most of the time, these patients are asymptomatic and the injury can be missed. And in the case of the MR cholangiopancreatography, you are going to appreciate an obstructed segment which lacks a continuity with the distal biliary tree. In contrast enhanced MRC, there's a focal duct dilatation and the lack of excretion of the contrast agent. We are going to appreciate the lack of excretion of the contrast agent from the bile duct at the site of the occlusion. When it is long-standing, it may be associated with the segmental atrophy. When it comes to the type C injury, again, there's a disruption or the transaction at the aberrant right hepatic duct, as you are seeing here, which is associated with the collection. This is a linear collection which is seen along the subhepatic aspect. So the type B and type C injuries, this is specifically, they are not picked up by the ERCP because the injured duct is not in continuity with the intrahepatic as well as the common bile ducts. When it comes to type D, that is resulting in the partial lateral wall injury to the common hepatic duct or the common bile duct. And they're always secondary to the misidentification of any of the major bile duct as a cystic duct. So when you're going to do the contrast enhanced MRC, you're going to appreciate the narrowing in the common hepatic duct or the common bile duct with the intact biliary G. And type E injuries, as we discussed here, it is at the main duct, common hepatic duct, with the which the classified into E1 to E5 based on the distance from the bile duct bifurcation and the involvement of the bile duct bifurcation, as well as the E5 is the involvement of the aberrant right hepatic duct. And they're usually due to the anatomical variants such as the low medial insertion of the cystic duct or cystic duct parallel to the common hepatic duct or the aberrant right hepatic duct. So again, in contrast enhanced MR cholangiopancreatography, we are going to identify whether the biliary confluence is there or not, as well as the length of the cystic duct are very well demonstrated in the contrast enhanced MR cholangiopancreatography. And the mechanism of the injuries, which includes the transaction, ligation, or thermal injury, or otherwise it's an occlusions. So this is an example of E1 injury where you can appreciate the confluence very well, and the injury is taken 2 centimeters away from the confluence associated with the collection, the biloma. This is another case where E2 type of injury, where there is you can appreciate very well the contrast within the CBD. This is an axial image at the level of the hilum of kidney. And when you go cranially, you can appreciate one hypointense area here. This is secondary to the This is a blooming artifact secondary to the surgical clip with a narrow common hepatic duct, and this is just 2 centimeter, less than 2 centimeter from the confluence. So this is E2 type of injury. In this, again, they have placed a percutaneous transhepatic stenting was done. This is a E3 injury where E3 type of injury that is seen at the confluence, but there is a preservation of the communication between the right and the left hepatic duct. And this shows an E4 injury where there is a the injury at the confluence along with the injury to the one of the hepatic ducts. And this is a case of E5 injury, which is associated with the E5 type of injury where there is a injury to the aberrant right posterior hepatic duct also along with the injury to the common hepatic duct. So the need for identifying the site of the bile leak, obviously the management changes based on the site of the bile leak. If it is from the cystic duct, usually they are managing with that of the non-operative, either with stenting or sphincterotomy. If it is right hepatic duct, that is a type B and type C, they are usually repaired through the image. It is percutaneous transhepatic cholangiopancreatography placement for external drainage. And when it is type 4, it is repaired with the primary closure and subhepatic drainage. If it is complete defect, it needs a bigger surgery. So it is always better to demonstrate the site of the bile leak, which helps the surgeon to plan their management. Next, coming to the topic of the biloma. So it is again, it's a well-demarcated collection of the bile, which is outside the biliary tree. The biloma can be seen in the subhepatic space and the perihepatic space. And it's very difficult to distinguish between the other collections which is associated with a surgery like a seroma or a lymphocyl or hematoma based on the ultrasound or CT. And in conventional MR, it's not very easy, as we discussed earlier. Only in the contrast MR cholangiography, if you are able to appreciate the excreted contrast in the biliary tree entering this collection, then with the confidence we can tell it's a biloma. If it is a walled up biloma, again, we won't be able to demonstrate the contrast accumulation within this fluid collections. So the mimickers for the bilomas include the normal postoperative fluid collection, which can be seen in the first week at the GB fossa, or the distended residual gallbladder following the subtotal cholecystectomy, or any hemostasis material like surgery can mimic the post-op bilomas, the postoperative collections. So what's the role of imaging in bile leak? We should, what the radiologist should know, they should know the variations in the biliary anatomy and the classification system that grade the bile duct injury for the proper diagnosis. And the modality of the choice is the MR, and the conventional MR cholangiography. It can identify the bile duct injuries along with the other complications like stricture, vascular injuries, and displaced gallstones. And it is supported by the next one is the contrast enhanced MR cholangiography, which provides the additional information recording the biliary excretion, and the exact site of the leak will be picked up with the contrast enhanced MR cholangiography. So when you detect in the proper time and localize the bile duct injury, it will help the surgeons and the physician to manage it to reduce the morbidity and mortality. With that, we come to the end of this talk. Thank you. Thank you very much.
Thank you very much, Dr. Kasi. You have stuck to, I must thank you for sticking to time. The only thing I didn't appreciate was you kept saying, you appreciate this image, you appreciate this image. We don't appreciate this image. We are terrified at this time. If it's our lap chole with leaking bile, we are totally terrified to see it. So that's just saying it in humor. So beautifully done. And that's a way to classify, which we do. Without taking discussions at this time, we'll go on to the next speaker, with your permission, who is Dr. Kumar Krishnan. He is the Assistant Professor of Medicine, Harvard Medical School. He is also the Director of Endoscopic Innovation, Technology, and Education for Gastroenterology, Massachusetts General Hospital, Boston, USA. He is involved on top of a lot of his academic journal associations. He is also involved in research, diagnostic and therapeutic technology in endoscopy, and minimally invasive treatment of intestinal disorders. He is the right person to speak on endotherapy for post-cholecystectomy bile leaks diagnosed by Dr. Kasi. Thank you. Dr. Krishnan.
Right, I'm going to share my screen. Thank you so much, Dr. Thanukumar and Dr. Kanagavo, for your kind invitation to speak at this wonderful meeting. And I learned a lot just from listening to Dr. Venkatesh. Let's see. This is an incredible honor and opportunity for me to speak to this wonderful organization. As mentioned, my name is Kumar Krishnan. I'm going to be speaking on endoscopic therapy for postoperative bile leaks. So you all have just heard a masterclass on how to identify the dreaded bile leak or bile duct injury. And now what do we do about it? So here are the learning objectives. I'll go over the role of biliary endoscopy in managing these leaks, from obviously simple cholecystectomy leaks, the type A's that you've heard about, to the unusual. If you will allow me, I'll give me a little bit of latitude. I'll talk about some of the more complicated bile leaks that we sometimes discuss, as well as some novel strategies to manage these leaks. Certainly, I'm not an expert on laparoscopic cholecystectomy. I put this slide only to remind the group that this is a relatively new technology that was first pioneered in 1985. And that time point is quite fortuitous because ERCP started gaining traction in the 1970s. So it's almost as if there was foreshadowing that you would need to combine both laparoscopic cholecystectomy with the possibility of some biliary endotherapy, because at least in the United States, this didn't gain traction until the late 80s. And as was alluded to in the previous talk, there were, in the early years, there were more complications, twofold increase compared to open surgery. And this was largely related to experience. And there was a study that was published in the 90s showing the highest 2.2% risk of bile duct injury within a surgeon's first 13 cases. And so it's important to remember that it's not the collective experience of the entire society, but it's each individual surgeon's experience. So we do see a lot more of these complications with new surgeons who come out of training and they're operating on their own, perhaps in the community. But we know that there is subsequent improvement over time. But nevertheless, this is an issue that we continue to have to address and deal with. And it's important to find optimal strategies for our patients. What is the incidence of bile leaks and bile duct injuries? The data is quite old at this point, but 0.3 to 0.6% incidence of bile leaks with laparoscopic cholecystectomy, lower for major bile duct injuries with elective cholecystectomy, and certainly a little bit higher for emergent cholecystectomy, probably related to all the patient factors you heard about earlier: sicker patients, more severe infections. And the rates are certainly higher in elderly patients. And I think that one thing that we all have probably realized is that patients who we are now operating on or doing procedures on are older, they have more comorbidities, they have more cardiovascular comorbidities, and we still have to take care of them. What does this translate to? At least in the United States, there are 300,000 laparoscopic cholecystectomies, and this translates to over 1,000 bile leaks per year. So this is a common problem in any large city hospital. You recently saw the radiographic findings associated with the Strasbourg criteria, which I think we all are quite familiar with. And I'm going to initially go through the type A injuries, which are the most common ones. And I hesitate to even call this a complication. This is sort of an expected outcome with a certain percentage, low percentage of patients. And when I teach my fellows about what are the principles of our role in managing these leaks, whether it's actually a bile leak or a postoperative leak of another kind, I still reference the old math textbooks and physics books and Poisson's law, which it takes me some time to remember all these components. But long story short, it tells us that our goal in endoscopic biliary therapy is to change the transpapillary pressure gradient such that bile will preferentially flow out the ampulla and not flow out the leak, especially if this is a cystic duct leak. And the parameters that determine how well we can change that pressure gradient is dependent on the length of the stent and the cross-sectional surface area. So this tells us that we should use the shortest stent with the largest diameter, and the focus should be on the transpapillary area, which is where the pressure gradient occurs. Some people suggest that perhaps we can just do a sphincterotomy alone, and in certain areas, perhaps with very small leaks, just by incising the sphincter of Oddi, we should be able to gain that transpapillary pressure gradient. However, I will mention that there are a handful of studies that have compared stenting to sphincterotomy alone, and resolution of leaks is certainly better with stenting compared to sphincterotomy alone. In one small prospective randomized controlled trial that compared endoscopic sphincterotomy to sphincterotomy plus stenting, resolution of bile leaks was twice as long with endoscopic sphincterotomy alone. And there are several reasons for this. Number one, there is typically edema and redundant tissue folds around the ampulla, which raise that pressure gradient. There are also small valves in the intraduodenal component of the distal bile duct that can raise the pressure gradient. And as we all know, the cystic duct fills retrograde after hitting this pressure gradient, flowing backwards and flowing out the leak. So it's imperative that we get adequate drainage, and typically this requires a stent in addition to sphincterotomy alone. There are a variety of different plastic stents available in a variety of different configurations. In Europe, there is now a biodegradable stent. I don't know if that stent by Medtronic is available in India. It's certainly not FDA cleared in the United States yet. In addition, there's a whole host of metallic stents that have a role, though this increased efficacy comes at a significantly increased cost as well to the system. So it's important to note that with endotherapy for bile leaks, we don't actually seal the leak. What we do is we facilitate normal physiologic drainage of the bile and dry out the component of the leak so that the body can heal itself. Whenever you have an ongoing leak, despite endoscopic therapy, it should raise the concern that a favorable pressure gradient has not been achieved. And it's important to note that in terms of the time to heal the bile leaks, there are various patient factors that can impact this, whether it's immunosuppression, nutritional status, age, vascular issues, et cetera. All of these can impact our ability to heal the leak, even though we want the output from that Jackson-Pratt drain to be zero on postoperative, post-procedure day 1 or 2. Sometimes that doesn't always occur. So what do we do with that initial non-resolution of leak? You have done your ERCP, you've identified the leak, you've placed one biliary stent, and there's that persistent output. I think, again, this should make us think about whether or not we've adequately treated that transpapillary pressure gradient. If the gradient across the leak is still much better than what you've accomplished by putting a stent, the goal should be multiple serial stents. And this can be in the form of straight stents, or my preferred method is to place multiple serial double pigtail stents. Keeping in mind that the aggregate diameter of the stent is more important than the diameter of a single stent, because the bile can flow not only through the stents, but around the stents, and we can perform impact the pressure gradients much more substantively with numerous stents. Covered metal stents are certainly very popular, especially for high-grade leaks. In the United States, we only have 2 available. I suspect in India, certainly in Europe, there are more available. There are many studies that have shown that for persistent bile leaks, placing a covered metal stent is a very effective initial measure. But again, this comes at a significant cost. And whether or not a single covered metal stent is better than multiple plastic stents, which is certainly much cheaper, is unclear. So when you have a non-resolution of a leak, again, I always tell my trainees, my fellows, that we have to go back to Poiseuille's law. Is the issue that there is a stricture that we're not addressing? In this case, there's a stricture at the level of the leak, of the cholecystectomy leaks. So clearly, in this situation, placing a transpapillary stent will not be impactful at lowering the pressure gradient across the side of the leak, and we have to then stent above the area of the stricture. We heard about aberrant hepatic ducts. This is another very good, though rare issue to keep in mind, that when you have persistent JP output, despite stenting, you may be dealing with an aberrant hepatic duct segments 5 through 8, which could drain directly into the cystic duct or drain directly into the gallbladder. And as Dr. Venkatesh mentioned very clearly previously, you will not see these opacified leaks with a positive pressure cholangiogram. And sometimes people assume that there are small Luschka branches, or even sometimes in the setting of surgery, you may have a cut surface leak. But when you have that situation in high output, it's imperative to go back to the radiology and assume that you may have an aberrant duct draining into the gallbladder that you can't deal with endoscopically, because you will have no ability to impact that pressure gradient. So we've seen the sort of the simple transpapillary, the simple cystic duct leaks, the Luschka leaks, sometimes the common bile duct injuries. Those are what I would call the good. How about the bad and the ugly? We'll talk about some of these leaks, and I want to pose a few cases to the group and get your opinion on how best we should manage this. So if you'll allow me, I'll present 2 cases. This first patient is a 29-year-old with chronic intermittent right upper quadrant pain, but no other past medical history. She underwent a laparoscopic cholecystectomy and was discharged the same day. Postoperative day 1 developed right upper quadrant pain, nausea, and then postoperative day 3 returned to the hospital with pain. CT scan revealed free fluid in the abdomen, and MRCP revealed mild intrahepatic ductal dilatation, and her total bilirubin was elevated. The patient was transferred to the Massachusetts General Hospital for further evaluation. So this patient underwent an ERCP, and I hope that you can see this, but initially on our occlusion cholangiogram, number 1, we don't opacify any intrahepatic ducts, and we start to see some extravasation near the hepatic hilum. And then upon positive pressure occlusion cholangiogram, we just start to see frank extravasation of contrast without any substantive intrahepatic ducts. We then perform cholangioscopy with spyglass, and as we get to the distal duct looks relatively healthy, but at the proximal duct, number 1, we don't see any bile, and we see a complete occlusion of the proximal hepatic duct. So thankfully, if you have colleagues like Dr. Venkatesh who are experts in performing percutaneous cholangiography, this was the next step that was performed, and you can see clearly the problem here. And number 1, at least for me as a gastroenterologist and not a surgeon, when I see this many clips near the hepatic hilum, it raises a sense that there's a problem. But you can all see very clearly here, this is what I would call the biliary equivalent of achalasia and the bird's beak, with no contrast draining distally from the common hepatic duct, mildly dilated hepatic ducts, and then a bile leak associated with this. So our radiologists place an external drain. They're certainly not able to gain continuity to the common bile duct, and they place a drain for the leak in addition to that. So if you will allow me, I'm curious what the group would offer for this patient. Would they leave the drain in? And if so, for how long? Would you try for bilateral drainage? Is this an option for Roux-en-Y reconstruction? And when would you do that? And lastly, do we have endoscopic options for this? And Dr. Thanakumar, if you want, I can just continue, or if you think this is a...
Well, this is interesting. What generally people would do is get the hepatic liver transplant people involved at this stage. And I've been told for similar things that they would go ahead and explore. Regarding the timing of exploration for an injury of this sort, I've been told the main one is hepaticojejunostomy. I've done that as well, but I've done it on the table when you damage the common bile duct. And they do it, and I've asked, how long do you wait? They said there's no waiting time. What Dr. Ela says is, you go in as soon as possible. I mean, he's one of the top transplant people. That's what he says. But, once you have a rendezvous, meeting place for both the top and the bottom, if you can get a track through with all the new advances, that's what we are expecting to learn from. We're hoping to learn from you. Such possibilities do exist, that you can, if you can make a tract and dilate it, leave it to settle down in course of time, get cultures and all that, you might be able to sort it out. But at this point in time, we tend to operate.
Wonderful. Dr. Thanakumar, it's almost as if you alluded to my next few slides already with that that discussion. So our surgeons decided to ask, could we provide some option for connectivity, and this is not always possible in all situations, but once that percutaneous drain was allowed to settle in, the patient was adequately drained externally, we brought the patient back, and you can see, as you mentioned here, there is a connection point, and it looks much better once you have external drainage for some period of time. So using a combination of glide wires and spyglass, we are able to finally break through that tract and follow the percutaneous drain access. Then combining with our interventional radiology colleagues, we're able to get an internal external guide wire and then place an internal external drain. We leave this drain in for some period of time, usually about 4 weeks, to let this tract mature. And then we come back and we remove the external drain. And because there was a little bit of distance from the confluence to the level of the obstruction, we ended up placing a covered metal stent in addition to 2 coaxial plastic stents. And then about 5 months later, after we allowed that stent to sit for quite some time, we ended up removing the covered metal stent and gained continuity. And I will say that this is certainly a very positive outcome, but it's not the outcome that we can expect indefinitely for some of these patients. They oftentimes will have recurrent stricturing from ischemia at the level of the common hepatic duct. And sometimes we do this just to buy time until our surgeons feel that, our hepatobiliary surgeons feel that they are ready for a hepatocogegenostomy.
Excellent.
What about an early hepatocogegenostomy? And I think many of our chief of surgery, Dr. Keith Lillimo, is an expert and has written many books and papers on bile duct injuries. And we've taken care of many bile duct injuries. And there's no question that in an expert's hands, that is certainly a good option. But these are very small ducts sometimes. And what we are left with is stricturing at the hepatocojejunal anastomosis and recurrent jaundice and problems. And once you create that hepatocogegenostomy, it takes some time and effort to reach it, either with a single balloon enteroscope or a double balloon enteroscope and repetitive stenting. And they sometimes, again, due to ischemia, small duct size, we do have to, can be quite challenging to take care of the recurrent obstructions. But this is a tough problem, and I can't say that there's one solution that's best for it, but I think it is important to know about the breadth of options that are available for some patients. And in these circumstances, sometimes they develop stricturing more upstream. This is a big problem. They develop almost an ischemic cholangiopathy or a secondary sclerosing cholangitis pattern, and we're left with numerous stents every 2 to 3 months until they develop cirrhosis, and then ultimately will get listed for liver transplant. So I wish I could tell you that it's a big success story once we gain continuity, but that's certainly not the end of it. They still develop biliary issues afterwards, and we still have to continue to work on these types of patients. It's my preference in terms of tools to use stents that have multiple side holes, similar to the IR drains that are placed. And I oftentimes in these patients will use stents that are actually meant for the pancreas because they have numerous side holes. Unfortunately, the biliary stents that are made are really not meant for these complex hilar obstructions because they don't have these features with them. So again, I know the focus is supposed to be about cholecystectomy bile leaks, but I couldn't help myself, and I hope that's okay with Dr. Thana Kumar, that I wanted to mention about how do we manage other bile leaks. And I think that this could be applicable to liver resections, et cetera. But this was a 65-year-old at our institution who had cirrhosis and HCC. He underwent a right lobe living donor transplant, and he was discharged on post-op day 6. He returned to clinic with fever and persistently high JP drain output, and he was admitted and treated for presumed sepsis, and a CT scan was performed. The CT scan was read as an increased size and organization of a bilobe perihepatic collection containing gas, foci of gas, and the presence of adjacent pneumobilia. Biliary leak is a differential consideration, and you can see numerous clips related to the right lobe living donor and also this perihepatic fluid collection. So here is our occlusion cholangiogram. You can see, number one, there is a low-lying cystic duct But upon our pressure cholangiogram, you can see that there is immediate contrast extravasation. This was an anastomosis with the right anterior and right posterior duct that were sewed independently to the recipient common hepatic duct. So this patient is now post-op day 7. They're significantly immunosuppressed. They had a recent liver transplant, and they don't have dilated hepatic ducts. So we obviously have different options, and our risk profile is different than the 29-year-old who had a cholecystectomy and a bile duct injury. But in the interest of time, I'll tell you how we manage this, and perhaps if there's time, I'm happy to answer questions and see alternatives. With a higher up occlusion cholangiogram, you can start to see that there are little bile ducts. This may be a branch of the right posterior that is impacted, and we see that we are accessing the biloma cavity, which is okay because we can also drain that internally. But with some time and effort, you can start to gain access to the right anterior duct, which is, as I mentioned, was non-dilated, and frequently these transplant ducts are non-dilated. We stent the right anterior, and then eventually we get access to the right posterior, and we can get anterograde drainage of bile. Unfortunately, these are not quick leaks to heal. These are immunosuppressed patients. They're sicker. These can take months and months and months to heal, as many of you all know. And as an interventional endoscopist, I pose the question, how do you avoid postoperative bile leaks altogether? And the answer is to don't operate. I would be remiss if I didn't mention, at least to this group, some alternatives. And I say this jokingly because we know that cholecystectomy is the gold standard. But again, as our patient population is older, is sicker, are there alternatives? And as you all are probably quite aware, with EUS technology, we have now the ability to drain the gallbladder in the setting of acute cholecystitis. This was a patient with cardiomyopathy, a heart transplant, had percutaneous drainage for cholecystitis, and simply was not able to do well with when the tube was removed. Thankfully, the gallbladder is frequently adjacent to the duodenum. You can see numerous shadowing stones. In this situation, we use an Axios cautery enhanced lumen opposing metal stent, which is the only stent available in the US for this. I believe in India, there may be a couple of stents that are available by Taiwan, but we can deploy the first flange, and then in our duodenum, deploy the second flange. And then soon after, we can dilate the stent. You can already see purulent drainage in this area. And then we can flush out the stones, remove everything, and then they will have a permanent tract or fistula. And of course, we would never do this in a patient who is a appropriate surgical candidate. This was compared to percutaneous drainage in a large multi-center randomized controlled trial. And I only bring this up to show that the 1-year adverse events, reintervention rates, unplanned admissions were significantly lower with the EUS gallbladder drainage. So for those patients who we are just hesitant to operate on, we have some good alternatives. I thank you all for your time, and I'm happy to answer questions. And I invite you to join us this fall in September in Boston for a minimally invasive and novel therapeutic course in foregut disease. Thank you.
Thank you very much, Dr. Krishnan. Excellent talk again. You stuck to time. It's very good. So many things to discuss with both of you. But I'll start up with Dr. Venkatesh Kasi, and as well as touch on you, Dr. Krishnan. You see, we talked about this bile leaks, but you know, now even on the table, the surgeon is so scared about lap choles, difficult lap choles because it's difficult. Easy cholecystectomy because that's when things go wrong. You assume, you know, the surgical hubris, you think it's simple, everything goes wrong after the surgery. And most of the time, we don't leave drains. So the patient goes home, comes back with a huge abdominal pain, and you know everybody's tensed up. So that's the problem. And we do the ICG now, not in all the hospitals, the fluorescent, to see whether we can identify whether the leaks before the leaks, identify the ducts. How much do you think this will come up in the near future? Do you think this will be the standard of care? You must be knowing the Strasbourg critical value. Critical view, and if you do you think this will add on to the critical value of Strasbourg at any stage? Maybe not under the same name, but do you think this will help you to decrease?
Yeah, Yeah, absolutely. I mean, I think that these types of assistive technologies, as they start to become more widespread, I know in our center we don't do much ICG. In fact, I would say across the United States, speaking to my colleagues, there's still very few surgeons who are willing to do a intraoperative cholangiogram in complex anatomy, and that may be due to time or inconvenience. Training, exactly. And so what has now become quite popular with some of our colleagues is the development of AI technology. And I've seen some very, very interesting studies from SAGES that have shown sort of the critical view, and the screen goes red when you're getting to danger zone, and the screen goes green when you're getting into your safe zone for your dissection. But I think the answer is yes. This should be done, especially in that early phase when a surgeon is within their first 30 to 50 cases. I think that's the optimal time to see the benefit.
And what do you think is the role of operative ultrasound in these cases to identify the common bile duct, etc.? I know the liver surgeons do operative ultrasounds, but how often do you think the laparoscopic surgeons should be doing operative ultrasounds? I know Nat Soper was the president of SAGES, used to write and talk about it a great deal, but somehow that's gone down a bit, and some of us trying to bring it up, because otherwise all the money is lost to people like Dr. Kasi trying to drain away all the money with MRIs.
It's funny, Nat Soper was the chief of GI surgery when I was an interventional fellow at Northwestern, and so I worked with Nat Soper quite a bit. And I also had the impression that all surgeons are doing intraoperative ultrasound. I thought it was a normal thing because he used to frequently do it. But
Absolutely,
then when I came to Boston, I realized nobody's doing it.
And the other thing I want to ask both of you, maybe I'll ask with Dr. Kasi. Dr. Kasi, why is it in India we don't do percutaneous cholecystectomy? You see abroad, like what Dr. Krishnan was saying, it's not an operation. Somebody who's got acalculous cholecystitis, somebody who's really sick, has got peritonitis, other comorbid problems, the average American surgeon wouldn't hesitate to put in percutaneous cholecystectomy. How come we don't think about it in India? Is it because you're not selling it enough?
Sir, if I'm not wrong, we are doing in our hospital, sir. Routinely, we are doing if the patient is very sick, and we are doing the percutaneous transhepatic percutaneous cholecystectomy. We are doing, sir.
Okay, that's fine. But supposing this question, Dr. Krishnan, you do a percutaneous cholecystectomy, how long do you leave the drain? This is for the audience because I know you didn't mention it. And what if the drain is continuous and keeps on going because the duct is small? Do you dilate the duct? Do you put a stent, for instance, through the cystic duct?
Yeah, so we actually are getting ready to publish our series about this. So there's sort of two options. So now at our institution, when somebody has cholecystitis and they're not an operative candidate, we sort of put them into two categories. Number one, they're not an operative candidate now. And number two, they will never be an operative candidate. So if they're not an operative candidate now, our approach is to do transpapillary gallbladder drainage. If they have a CBD stone, then we'll do an ERCP, remove the stone, and do an endoscopic transpapillary stent. If they don't have a CBD stone, then we will do a percutaneous cholecystostomy tube, and our interventional radiologist will internalize that after 4 weeks. If they are never going to be a surgical candidate, then we opt for EUS-guided transluminal drainage of the gallbladder.
Okay, right. Endo ultrasound also has come in a big way in India. We drain pseudopancreatic cysts, etc., which is out of the scope of this talk. So that's something we do as well. And it's nice to see, I'm always terrified to meet the interventional radiologist because, something has hit the fan when you have done your lab chole, and that's the time we get to meet you guys. So I'm always terrified about meeting you, but both of you made the topic so pleasant. If there are none, then I'd like to thank Dr. Kasi and Dr. Krishnan for the excellent talks you have, the great time we have had today in learning from you. Thank you very much.
Thank you, sir. Thank you,
Dr. Kanagavel.
I have a couple of questions to both the speakers. Dr. Kumar, many times we are being called up to handle intraoperative bile duct injuries during performance, or we have been referred patients for a bile duct repair. So let us start with one issue at a point of time. Doc Plexus team, can we mute the person, please? Thank you. So I would like to ask, say for instance, many times if it is a very limited injury or if there is a possibility and you have the expertise, you go ahead with the on-table repair. And then we always leave a stent, either a T-tube or an internal stent into the duodenum. And at times we find difficult to take the ends together. So that is where we end up in trouble. So do we have an option like it looks now with endo ultrasound, you are able to get into a, say for instance, I've went through recent publications telling in ampullary carcinomas and advanced tumors where we end up doing a bile duct to the stomach, transgastric stent placement into that. Is there any publication or is there any attempt for bile duct injuries to primarily take assistance from endotherapy and try to do an on-table repair?
I'm not familiar with that approach. There are situations where, we can obtain a hepatic cholangiogram, pass a guide wire anterograde from the stomach. But I still think that permanent drainages via EUS are probably not ideal for this patient population. In the setting of cancer, non-operative candidates, we frequently do EUS-guided biliary drainage. But in the setting of benign disease, you'll be left with a chronic tract and fistula, and it'll get obstructed. You'll have a sump syndrome. And so I think for those situations, doing a primary EUS type of repair probably is not going to be long-term beneficial.
Am I thinking it loud, like with the advancement of stents and other things? Do we have the option to take an assistance from an endotherapist? Say, for instance, if you're going to have 2 centimeters of common bile duct left or 3 centimeters of common bile duct left, and below which there have been a segmental loss, is there a possibility or is there anything which is coming up on an experimental basis where we can directly take a endoscopy assisted anastomosis to the stomach or to the duodenum possibly?
Via EUS, it would be challenging because the duct will not be as dilated as you would expect with cancer. So you have a very small target, and the stents that we use are quite large. So I think it would be quite challenging.
May I suggest an answer? Vellore used to do the anastomosis to the first part of duodenum, not into the stomach, because one, it produces reflux gastritis, the bile coming to the stomach is an irritant. Second thing is the West always thinks that it is an irritant to produce a carcinoma stomach. So for a benign condition, if you do this permanently, the guy is very likely to land up, say, 10 or 20 years from now with a carcinoma stomach due to a secondary procedure. So probably if you have to do it, you can put it in the duodenum itself, in the first part of duodenum beyond the sphincter body. That's what we used to do for recurrent strictures of common bile duct of the lower part, especially associated with lap choleus. We used to put it into the first part of duodenum. That's something you can do surgically, but I think you need to get a lot of on-the-table conference before you do that, because it's not, as you rightly said, it can be thought about, but not one of the standard procedures.
Perfect.
What is your thinking?
Dr. Krishnan, the next question which comes to every surgeon is, for an across clipped common bile duct, assuming that we have not transected, the surgeon has the video of clipping the duct accidentally and coming out. When these patients are referred to you, what are your special strategies to gain access to the proximal system when there is a titanium clip which is running across the common bile duct? And many times we find difficult to pass in the guide wire at all. So do we have any specific strategies? And at least let us hear from your side, what is your strategy for these type of total occlusion of the common bile duct with the clip?
Yeah, so step number 1 is to get a good invasive imaging. So that will oftentimes require ERCP to see below the stricture what your anatomy looks like. And then we have thankfully access to very good interventional radiologists, so they'll do a drain from above. we can try to see if we can connect the two. And the way that we would try that is by the use of various glide wires, dilation catheters. Sometimes we have what's called a Sohendra screw retriever that can kind of corkscrew. But frequently at this point, the long term is such that they're probably going to be better off with a hepatocogaginostomy just above the clip. So this, again, is a multidisciplinary discussion with our hepatobiliary surgeons. If for whatever reason they feel the patient has a high morbidity for doing those things, they may ask us to try. And the key thing is if we are able to get access across by a percutaneous and retrograde combined access, I would strongly recommend that is not the time to leave a transpapillary stent. That's a time to leave an internal external biliary drain, let it mature, and then wait a month or two before you try to internalize everything. Because as you know, sometimes the patients will beg you, oh, I don't want to drain, get the drain out as fast as you can. And then there'll be a temptation that you have a guide wire across to put a stent. If that stent slips, if it migrates, if it gets occluded, then all of a sudden you'll be starting from the beginning. And so those chances are less likely than with an external drain.
And the next common issue all of us face are forgotten stents, getting stuck stent into the bile ducts for various reasons. What is Harvard's strategy to pull out those stents which are just stuck and refuse to come out?
So with plastic stents, I would say that we are, thankfully, we have a lot of strategies. Well, whether it's sometimes what you can do is adjacent to that stent, place a couple of new fresh stents, you'll get a tissue necrosis. And this is all for the bile duct, a different ball game in the pancreas. And then you can remove it after about 3 months. Sometimes you can place a fully covered metal stent adjacent to that stent. And then again, you'll get a tissue necrosis because it's usually difficult because the stent has embedded itself. The flange has embedded itself into the tissue and you have some overgrowth. So you have to get rid of that. Sometimes you can do intraductal RFA and ablate that tissue and remove it. All options. The worst is when, unfortunately, somebody places an uncovered metal stent in a benign situation. That is a very, very difficult problem. I've done many things to try to remove them, place a fully covered stent inside the old one. There's a great video in Gastrointestinal Endoscopy Journal where somebody had looped, I think this is a group in Turkey, they looped an 035 Jaguar below the bottom of the stents, the holes of the metal stent, and they used a Sohendra lithotripsy cable and was able to unravel that entire stent. I've never seen anything like that, but I haven't tried it myself, but that's one option. And then covered stents, I would say a lot of times there's a little technique issues. People want to pull the stent through the channel, when in reality, they need to push the scope and pull the stent along the axis of the bile duct.
That's brilliant. And thanks for sharing all your secrets of handling tough. I will take a minute to a question to Dr. Venkatesh. Dr. Venkatesh, with the interventional radiology having access to at least 2 millimeter, 3 millimeter blood vessels, how far it is safe to access the obstructed biliary tree through a transvenous or a transarterial access? Is that allowed? It looks pretty much doable by a radiologist. Do you have any experience in doing that? Or is it a very crazy idea to think transvascular access to the bile duct, proximal system especially?
No, sir, our IR team, as far as I know, they didn't try this one, transvascular approach to bile triangles.
No, it is one of our postgraduates question. In fact, I don't have an answer. So I thought I will put up to this for,
no, sir.
Because he always feels, sir, portal vein is accessible, hepatic artery is accessible with all the endovascular access. So bile ducts are pretty much close. A dilated bile duct, common hepatic duct or right duct can be easily punctured across with the vessel. I don't know, it sounds very crazy, but it looks very doable because that is a very easy way to access to the proximal system, especially it's a totally obstructed, high obstructions or high injuries. So
some bile in the blood is no big deal at all.
I can tell you inadvertently on a cholangiocarcinoma patient, I had the wonderful pleasure of pulling out a stent and obtaining a portal venogram from the ampulla, which that resulted in a significant tachycardia, not for the patient, but for myself.
Thank you for being honest.
And
And-
either of you, do you do this ablative gallbladder surgery? I mean, endoscopically do the ablative ablation of the gallbladder with cryo? I know Dr. Kasi has got this new cryo probe in COVID Medical Center. Do you ever venture that you'll take over the function of removing somebody's gallbladder with ablative frozen cryo?
So is it Dr. Kumar or is it
No, for you, sir.
Either of you. You're all case. Krishnan, Kumar, Kasi, same.
So as far as from our point of view, the cryoablations, there are only few indications where it is used as a curative one. So for example, in the renal tumors we are using, for the lung tumors we are using the cryoablations, and for many cases we are using it as a palliative purpose. And if the patient is, most of the time when it comes to the ablation from our point of view, if the patient is fit for surgery, it has to go for the surgery. If the patient is not fit for surgery, then it will be taken out by the IAGES.
Okay, point taken.
Yeah, and similarly, we would drain it with EUS, endoscopic ultrasound.
Sure,
That would be
right.
our approach.
Right, okay.
And Dr. Kumar, one final question. With huge biomass, especially complicating access for both your ERCP as well as for us surgeons to have access to the injury point at all, do you have any experience doing a stent from the biloma to the enteral, any of the US guided, say for instance, if you can do a gastrobiloma stents or duodenobyloma stents, because that looks very doable, because with say half a liter of biloma, with the pushing all the systems down, and with the US stents to the pancreas, it looks definitely a doable thing. Do you have any experience in that as a temporary measure?
Yeah, it's been reported, but I will just mention that the drainage of the gallbladder or drainage of pancreatic pseudocyst is truly functionally different than trying to drain a biloma. Biloma is not going to be quite as mature, and so we really rely on the maturity of the cavity around that collection. It typically does not impact the ability to do an ERCP and at least put a stent to no longer feed the biloma. So while all of these things are possibilities, I think that the only gain that you have is to avoid the percutaneous drainage, and but I think that still would be standard of care, because if there's not a thick rind around that biloma, what you'll end up having is now a fistula from the stomach to the perihepatic space, which is a much bigger problem to deal with.
Thank you very much. And one other question, I won't categorize that as bile duct leaks. Many times we face rare situations where thermal injuries while having a cholecystectomy to the duodenum or to the right colon, the hepatic flexure especially, and we end up having a enteral peritonitis. Do we have experience in handling either with the OTAC clip or stent, covered stents for duodenal thermal injuries or colonic thermal injuries during cholecystectomy?
Yeah, I will say that I have managed a lot of postoperative leaks. I can't say if it was from cholecystectomy. There have been a lot of pancreatic tumor resections that ultimately will have some sort of injury or fistula. In the upper GI tract, my general approach, if it's acute, we'll try to close it. If it becomes somewhat chronic, I think closure ends up becoming very challenging because it's quite ischemic tissue, and the clip just ends up falling off. And then we go for what's called endoscopic internal drainage, which is the same approach that we would take for these types of bariatric leaks or fistulas. But also endoscopic suturing, I would say, would be much more reliable in my mind than the OTSC clips.
Okay, endoscopic suturing is available for both the upper GI as well as colonic, sir. Do we have devices which can handle both?
It only really fits in a gastroscope, so only for upper for the most part.
Thank you very much. And Dr. Venkatesh, what do you think will be the next major breakthrough from your radiology perspective on this management? What is on the pipeline?
No idea.
Thank you very much. And Dr. Satish Midha, we'd like to hear your comments, sir, before we call a close.
Thank you very much. I think many of the cases really need endotherapy, and we have seen many advancements now. Though I'm a surgeon, but I also do many of the endotherapic work myself. So I think it's a boon for us that now we are able to manage many of these cases with the endotherapy, especially the bile leaks. Many can be managed, and it's really an important topic. So I think we had a good discussion.
Thank you very
So,
much, Dr. Vidya, sir.
I would like to formally thank also
Please.
Dr. Kumar Krishnan for sharing his wisdom on this very important topic. We know that laparoscopic cholecystectomy is one of the commonest surgeries being done, and though the incidence of CBD injury has come down, but still the absolute number is quite high. So even if it's less than 0.1%, 0.01% or whatever it is, so still we have problems, and we have to manage these cases. And now many of these cases can be managed by endotherapy as well, but some may need surgery depending on the nature of the injury. And thank you for being with us in the early hours of the morning from your time. And thanks, Dr. Venkatesh, for sharing your knowledge about the diagnostic test, because it's important to diagnose problems appropriately so that it percutaneous part, I think, which is not done in many centers, but still being done by the few centers. Thank you very much. Thanks, Dr. John Thanakumar, for moderating the session very well and sharing your knowledge also.
And have a good holiday.
Thanks,
You're
Dr.
obviously in Europe.
Nagville, for being part of this program. I am in Prague, and thanks the president, though he was traveling but he sent in. Thanks DocFlex team for arranging this prime time, and thanks all. Good day and good night to all of you. Thank you very much.
Thank you very much.
Thank you, sir. Dr. Kumar and Dr. Venkatesh, it was a pleasure to host you. And it is always a fatherly person to share with our stage. Dr. John has been always extending help for any of the academic help we have been asking. Dr. Kumar and Dr. Venkatesh, soon we will plan a combined meeting on biliary leak endotherapy as a combined CME with IAGES and Harvard School. Maybe we will conceptualize in also in taking consensus with the president and the team of hepatobiliary laparoscopic surgeons with IAGES. So maybe September or October, we will conceive an idea and we'll have an online program. Hope that works well with you, Dr. Kumar Krishnan.
Yeah, that would be great. I think this the one thing I want to highlight is that none of this is done on an island, and it's this collaborative nature with radiologists, surgeons, hepatobiliary. That's really how we can advance care.
Thank you very much. Thank you, everyone.
Goodbye. Good morning and good night. Bye-bye.
Thank you, sir.
Thank you.
Thank you so much for this opportunity.
Bye-bye. Yeah.
Thank you.